Hello, everyone, and welcome to Arthritis and COVID-19, Vaccines, Access, and What's Next. I'm Dr. Sean Bevan, Chief Science Officer at the Arthritis Society, and it's nice to be able to come together with many of you again. For those of you attending an Arthritis Talks webinar for the first time, welcome. We're now a year into the COVID-19 pandemic, and there are still so many questions to be answered. We know that the need for trusted information about COVID-19 continues, and we are delighted to bring back Dr. Vandana Ahluwalia and Dr. Alan Lowe to share their knowledge with us today. These experts have literally been on the front lines for the last year, helping people with arthritis safely manage their health throughout this difficult period. Before we get underway, just a few logistics. This webcast is best viewed on a laptop or desktop computer. If you have any technical issues, please email support@webcastcanada.ca for assistance. We always recommend that if you're having a technical issue with the video during the session, try refreshing your feed before emailing technical support. If you're having audio issues, you may need to click on the Turn Audio On button at the bottom left of the webcast window. If you have a question for one of our presenters, you can submit it through the Ask a Question section at the top right of the screen. We will try to get to as many questions as we possibly can during the hour that we have together. You can click on the chat window on the right of the screen to connect with our participants and the Arthritis Society's chat moderator. If you'd like to close the chat completely, go ahead, click the icon on the bottom right of your live stream to view the webinar full screen. We're also now using open captioning during our sessions to accommodate the needs of our diverse audience. You'll see that also running at the bottom of the page. Many of the questions that we received followed similar themes, so Dr. Ahluwalia and Dr. Lowe will first address those first questions through the slides before we get to the live Q&A at the end of the session. Before we get started, I just want to take a moment to thank our event partners, Pfizer, Novartis, United Way Winnipeg, the Province of British Columbia, BMS, UCB, and Cordelex for their financial support of our Arthritis Talk series. So with that, let's get started. Dr. Ahluwalia, welcome. At the beginning of the pandemic, there were so many concerns, as you know, about how COVID-19 would affect people living with arthritis. So could you just give us some insights to start off about how COVID-19 has specifically affected people living with arthritis?
Thank you, Sean. It's my pleasure to be here today. It's been a year since we last spoke to you on COVID-19, and I'm sure that you're hearing lots on the radio, TV, in newspapers, and on social media. The information continues to be changing daily, weekly, and monthly, so we've tried to give you the most up-to-date information possible. I'm joined again by Dr. Alan Lowe, who is a pharmacist in BC. I'm a rheumatologist and not an infectious disease specialist. So the knowledge we are imparting to you today has been obtained from published research, guidelines, and from my infectious disease experts. COVID had its birthday on March 11th, but we were not celebrating. As a result of this pandemic, there's been a significant number of human deaths, economic losses, and effects on mental health. However, there seems to be some light now at the end of the tunnel with the rapid development of a vaccine through global collaboration and global benefit. In the last two sessions, we talked about how to prevent spread of COVID and how to protect yourselves if you have a rheumatic condition. This session will be focused on the emergent vaccines for COVID-19 and managing rheumatic diseases through the rollout. There was an opportunity to send in questions in advance through the Arthritis Society website for this session. The most frequently asked questions were around these 5 topics. So we're going to start with those, and we will have time at the end, as Sean mentioned, for more questions and answers. So the first theme was, are people with arthritis more susceptible or have more severe COVID symptoms or disease? What have we learned about COVID-19 and how it affects people with arthritis, and how can it be treated? What are the rheumatic disease medications used to treat COVID-19, and should we be worried about drug shortages? Vaccines, how are they made? How do they work? benefits and risks, rollout, and when is it going to be your turn. And finally, how to manage your arthritis while being eligible for vaccination. At the session we did last April, I reported the beginning of the Global Rheumatology Alliance. This online registry is an international effort to collect information pertinent to the COVID-19 infection in patients with rheumatic diseases. And it also included all the diseases that we as rheumatologists treat. So far, about 6,300 cases have been registered, and research around these cases is starting to be published. So the first question is, are people living with arthritis more susceptible to COVID-19? Well, the question really is who is at most risk of severe illness from COVID-19? We know that age is still a major risk factor. That's why vaccination has begun with older people, as they are the most vulnerable. So people above the age of 60, those with underlying medical problems like hypertension, heart and lung problems, diabetes, obesity, or cancer are at higher risk of developing serious illness. We know that from the studies that have been done. However, as you know, anyone can get sick with COVID-19 and become seriously ill or die at any age. So the question really is what evidence do we have so far about patients with rheumatic diseases and the medications that are prescribed for them? So this study was done through the Global Rheumatology Alliance Observational Database. 600 patients were studied with rheumatic diseases who were hospitalized with COVID-19. So as you can see in the graph on the left-hand side, the left-hand column has the patient factors, which we just talked about. And then below that, you have the medications that are taken by patients with rheumatic diseases. On the right-hand side, what you see is this sort of line graph, lines going all across in different colors. In the center is the line of unity, or 1.0. This is actually an odds ratio graph. The odds ratio is really the measure of a strength of an association with an exposure or risk factor and an outcome. So let's say the risk factor is age. Then the question is, how does it affect the outcome of having COVID-19 and being hospitalized with it? So if you look at the line of unity, below the line, the strength of association is weak. Above the line, the strength of association is stronger. And as the number goes up, the strength is actually stronger. So if you look at the risk factors at the top, or the blue lines going across, you can see that the odds ratio is about 3.0, which is actually quite high. If we look at the medications prescribed for rheumatic diseases, and you look at disease-modifying agents, which the commonest is methotrexate, you can see that the odds ratio of being hospitalized with COVID-19 is 1.3, which is actually quite low. However, if you look at another medication, which is prednisone, which is commonly prescribed for rheumatic disease, you can see that the odds ratio is 2.0, a little bit higher, more on par with the other risk factors. So this is one study. So we really have to show similar results in other studies. So if we look at studies from Spain, New York, Boston, and Italy, show similar results. Most medications used to treat rheumatic diseases do not increase your risk of severe COVID-19 and hospitalization, other than perhaps prednisone. So let's look at another study. This is the risk of dying from COVID-19 in patients who have rheumatoid arthritis. This was a study specifically done in this patient profile. And they found three very interesting things. The first is that moderate or high disease activity is associated with potential death from COVID-19, because if your disease continues to be active, then you have a higher risk in terms of the infection. The second thing that was found is that most medications used by people with rheumatic diseases were not associated with a higher risk of death. So you can see on the right-hand side, the blue box that are the usual medications that we may prescribe in patients with rheumatoid arthritis. However, there were a few medications that did come out as higher risk. One of them is rituximab, second, sulfasalazine, third, some immunosuppressants, but these immunosuppressants are not commonly used in patients with rheumatoid arthritis, such as Cellcept or azathioprine or cyclophosphamide. But what was also very interesting, as I mentioned in the first bullet, is that disease-modifying therapy, if you're not taking any disease-modifying therapy, potentially your disease could be active and that would put you at higher risk. So the bottom line is taking your medications as prescribed and controlling your disease can lower your risk of death from COVID-19. So you might ask, well, how does that work? I have an autoimmune condition, I'm immunosuppressed. Why am I not at an increased risk of getting infection or dying from the infection? Well, we may know a little more than we did about a year ago. We know that serious illness and death due to the virus is due to what we call an immune activation and inflammation. So what happens is actually not the virus that causes the serious problems. It's your immune response to the virus that causes inflammation in the lungs that results in lung dysfunction. It's something called a cytokine storm. So it's possible that your disease, if you cannot mount that immune activation because your disease is suppressing your immune system, or perhaps even your immunosuppressive medications are suppressing your immune system, you cannot mount that inflammation in a sense that almost protects you. And in addition, some immunosuppressive therapies are being used to treat serious viral complications of COVID-19. There's one other possibility. This study looked at patients with rheumatic diseases and what kind of isolation practices they used. It's very interesting what they found. A questionnaire was given to patients with rheumatic diseases, about 1,000 patients with all different rheumatic diseases who came to the rheumatic disease clinics versus healthy controls. What they asked them is what kind of isolation practices they used. Did they use mild isolation, hand hygiene and physical distancing, or did they practice strict isolation, staying indoors and isolating themselves from friends and family? Very interesting what was found. 46% did strict isolation practices. This was 2 times higher than the healthy population. So in the end, maybe it's because you are practicing strict isolation more often because you are concerned about your condition as well as your medications. So the bottom line, as we saw in the previous studies, your disease is not necessarily associated with worse outcomes compared to the general population unless it is poorly controlled. So it's very important to take your medications as prescribed to keep your disease under control. There are a few medications such as rituximab and prednisone, which may put you at a higher risk. But what is interesting is that protecting yourself using all the public health measures that you have been doing and probably doing better than anybody else continues to be very important until you get vaccinated.
So Dr. Lowe, from your perspective, what have we learned about COVID-19 and how it affects people with arthritis? And importantly, how can it be treated?
Thanks, Sean, for that question. We have learned a little bit more since the past year. So let's start off with knowing a little bit more about COVID-19 and how it attacks the body. It certainly has a preferential entry point, and that's usually through the lungs or our respiratory system. And with that, it's where it generally infects. However, it can also infect other body systems, including our cardiovascular system. It can hit kidneys, it can hit the liver as well, and also gastrointestinal tract. Now, some people also have these lingering symptoms that can prolong after the infection with COVID-19. And it's defined as a 28-day symptom that still continues from the acute infection. Sometimes these folks are referred to as long COVID or post-COVID long haulers. And I'm sure you've heard some of that in the news. Now, genetics, comorbidities, age, level of health, all of these certainly play a role in the likelihood of catching COVID-19, as well as its severity of the symptoms and which organs it can affect. As with most viruses, they have to enter somewhere. And this is where the hand washing, using hand sanitizers, and being very diligent about not touching your eyes, nose, and mouth is particularly important, because that's where generally it's going to enter into the body. Sanitizers make sure it is 70% alcohol and higher, just to make sure that it does destroy the virus, because lower alcohol content may not. So before eating, always make sure you do wash your hands. Also, there's a number of treatments that are under study with COVID-19, and there's actually many that are being studied. And in fact, one of the studies that I'm involved with at the pharmacy is we're looking at inhaled and nasal corticosteroids being used. It's a study by the McGill University for symptomatic patients who are COVID positive, and it's being compared to placebo. So it means that we're not sure which medications work and have to compare to essentially a sugar pill or a placebo control to make sure that we're getting the positive effects. With respect to some other IL-6 blockers, and one of them is tocilizumab, Actemra is the brand name, it's thought to reduce that cytokine cascade that Dr. Ahluwalia was mentioning. And as a result, this is being tried. However, it is only being used as really supportive measures and not routinely. So these are for hospitalized patients, sometimes in combination with other treatments as well. There's other treatments that you would have heard that are being studied. Some of them are further along than others. So some drugs like colchicine, dimethyl fumarate, ACE inhibitors, and angiotensin II blockers are also been studied. Statins, anticoagulants, and even vitamin D has been looked at. With respect to vitamin D, it's really ensuring that there's adequate levels of vitamin D in the body. And sometimes that's a bit of a concern because depending on where you live and the season, there may not be enough sunlight that you're getting sufficient vitamin D. But it's really about making sure the body has enough of its usual nutrients. There are very few proven COVID-19 treatments that are out there. So some evidence is available for remdesivir. And again, it's used when there's a lung infection that's severe enough that causes hospitalization. So this isn't for routine use again, and really for hospitalized folks. The evidence for dexamethasone has also been published, and it's again, particularly used in patients who are being ventilated, that is a breathing machine, or have received oxygen, and again, in the hospital. The doses aren't really high. There's 6 milligrams used once per day, up to 10 days usage, sometimes 14 days. There's also some preliminary data for a drug called baricitinib. That's a JAK inhibitor, sometimes is used in some rheumatology conditions, together with remdesivir, and again, in hospitalized patients. The dose is not something outrageous. It's 4 milligrams once a day for up to 14 days. So what you're seeing is not a lot of usage because it's really just hospitalized patients that are receiving these kinds of medications. So it should really allay the fears of possible drug shortages. We do have enough drugs to supply and to be used in these clinical trials, as well as to be used in these patients who are being treated. So it's not going to affect the drug supply, and there's not a concern there. Interruption of distribution of drugs is just normal and always a concern. Many of you have already heard in the news with respect to the Suez Canal, things can just happen. We have mishaps that can delay deliveries, that can delay transports of supplies and etc. So these kinds of things are unpredictable and can happen at any time. We do, of course, need to be forward planning and pay attention to transport and storage conditions, which are very important. And there's always higher production of drugs than what's normally ordered. So even with respect to the COVID vaccines that are being produced, based on the orders, the manufacturers always plan to produce more, again, to account for mishaps and possible changes in unpredictability. What's very difficult is, despite the best plans and even overproducing to a certain extent, it's very difficult to deal with unpredictable actions and occurrences. So individuals who are going to hoard or take extra drug supply just to store in the cupboard, and sometimes they go unused and are expiring and therefore get completely wasted, is a real problem that's really unpredictable. Some of you might have seen what's happened with artificial shortages, such as with the toilet paper that we saw. We were never in a shortage situation, but if everybody's going to buy 3, 4, 5 times the amount they're normally going to use, that just causes a run on some of these products, which is kind of this artificial shortage that occurs. With respect to ensuring that there's no wastage and no waste of health practitioners' time, making sure that you make your appointments, show up as directed, be ready, and avoid that waste of resources. So if you can't make an appointment, certainly let somebody know as soon as possible to make a cancellation. Canada in general for drug supply has a very good monitoring system. There's regular meetings that are multi-stakeholder meetings, which are represented by healthcare providers, as well as patient organizations as well. Some of you might be wondering, why are arthritis and rheumatologic medications being used to treat COVID-19? And as you can tell in some of the things that we've mentioned, it's the cytokine storm, or the production of inflammatory cells, inflammatory mediators actually, that are causing problems and making our body react and have the symptoms from the infection. So if we can use immunomodulating drugs, it makes sense that we can maybe decrease some of those reactive mediators and therefore reduce the symptoms. So these complications essentially is because the host cells are replicating virus, and the body is producing an immune response to try to block the replication, block the damage, and try to, of course, knock out the virus itself. So these arthritis drugs that are immunomodulating are sometimes tried and used, and that's why the postulates and hypotheses are there to consider maybe using these drugs as a potential for treating COVID-19.
Thank you, Dr. Lowe. Clearly, we've learned a lot in the last year, but maybe the best news is that we now have a vaccine or multiple vaccines available to us. And there's lots of questions already in the Q&A. I assume that this will dominate our session at the very end, but to start us off, what do we know about the vaccines that are currently available or will soon be available that you can share with us?
Thanks. Hopefully I'm going to be able to answer some of those questions as I go through. Certainly, for that question of should you get a vaccine, the answer is a clear, absolute yes. Get the one that you're eligible for that's first offered to you. There is a COVID vaccine race that's going on. There are over 200 or close to 200 vaccines that are currently being developed. We do know these vaccines, they prevent infection, they reduce hospitalization, and they prevent death. They've also been shown in some cases to reduce the carrier state. So that means being asymptomatic and harboring or having the virus. Worldwide, there are 13 COVID vaccines that are approved in one country or another. They generally use one of three platforms, and I'll talk a bit more about that later. But you can see through this pictorial here that in preclinical or development stages, there are about 182 vaccines that are being developed around the world. 28 of them are in phase 1, which means they're being tested in healthy volunteers to make sure that they're safe. In phase 2 is where some of the dose ranging occurs to identify what is the best dose. And it's important to realize this, that even the doses have to be tested. It's not about just the efficacy and safety of the vaccine, but it's how many doses to give and what dose to give needs to be studied as well. Once a good dose is identified, then it moves on to phase 3, and there's 20 that are in the phase 3 development, and then the 13 that are approved around the world. 5 of them have been marketed and in a stage where there's a lot of post-marketing surveillance that goes on, and that's considered phase 4. Vaccines are becoming much more available as we're able to get supply and shipment. There are 4 that are approved in Canada, so Health Canada has officially approved these. However, not all of them, despite being approval, are out there shipping and ready to be used, and that is the Janssen vaccine at the bottom. So although that one's been approved, it's not yet available, but will be available very soon. There are various mechanisms of how these vaccines might work, so different vaccine platforms. And again, based on the dose ranging is how they determine whether it's 1 or 2 doses. So the Janssen vaccine, there was no difference when they did testing, whether they used 1 or used a second dose. And if there's no added advantage to a second dose, there's no point in, of course, giving it. And that's how we arrive at giving 1 dose. Versus the other vaccines did show that the second dose added some additional coverage. These vaccines also have different storage requirements, as you can see on the graph. And the deep freeze storage, of course, is most difficult. Freezer, not so hard. And refrigeration is a lot easier. Certainly, we're very familiar with dealing with refrigerated medications. However, it does also mean that in rural communities, it's going to be harder to get vaccines that are in the deep freeze to be transported. So here's some of the mechanisms. One way is to use this viral vector mechanism. Essentially, it's using an adenovirus, which is a common virus, but this one is non-infective. It's just used as a carrier. So imagine inserting DNA material into this adenovirus. It can then enter the body's cells, and then it releases the DNA material that's inside of it, programming the body cells to build antibodies, to build spike protein that is connected to the COVID virus. By stimulating the body's response and building antibodies to that COVID spike protein, we're able to train the body essentially to prepare for and attack the COVID virus right away. So it's kind of a training exercise to get it to look for this identifier, the spike protein. Another way is using nanoparticles. So Arthritis Therapeutics actually developed a lipid nanoparticle that actually delivers RNA, the mRNA material, into the body cells. So through this video, you can see that this lipid nanoparticle enters the cell. The yellow DNA material is released, causing the body cells to produce this red protein. This red protein in this case is the COVID spike protein. Our body will then be able to recognize it and build antibodies. Remember that this is not the virus being inserted into the body. It is just a genetic material programming your own cells to build a tiny piece of the COVID virus, which doesn't cause infection, so that the body can build a response to it. And this one has a very interesting story. Arthritis Therapeutics is actually based at the University of British Columbia, where I teach. And this is really earth-shattering, groundbreaking type technology. So to be able to have a targeting particle that can enter the body into specific cells, being able to deliver a recipe to the host or to the body, to be able to build, essentially use the body's machinery to build a protein that your body can react to in a controlled environment. So during this response, this is what some of those side effects you might see from a vaccine is, and that's because it's showing that your body is responding. It is building that immune response. And by building that immune response, sometimes we're going to see what are like cold flu-like symptoms. So here are some of the vaccine key points that you can take away. So all these vaccines are stimulating the body to build its own defense system. This way, when a real exposure occurs with the virus, it's able to attack it and mitigate it right away. The body, however, can forget these defense maneuvers, or the virus might mutate and create other variants. And then that way, the body either has to adapt, or the body may not remember or recognize this mutated or variant form. And therefore, we can run into problems where we may be looking at future immunizations on a regular basis, much like we see with the flu shot. Because these vaccines are made with proteins, this is why they have to be stored in a cold environment, whether it be deep freeze, freezing, or in the fridge. These medications, vaccines have to be injected because, again, they are proteins, and if taken orally, they just get digested in our gastrointestinal tract. The current vaccines do not contain any COVID-19 virus particles. There are other vaccine platforms where you can take a piece of that virus that's non-infective and expose it to the body so it can build antibodies and, again, have that defense mechanism. But the current ones that are available are not containing any portion or real virus at all. So it's not a weakened virus. It is not virus particles. It is actually teaching your own cells to build the spike protein, a very small portion of the virus. We know that vaccines, again, reduces the severity of the infection. It reduces hospitalizations and prevents deaths. Vaccines can help to prevent spread as well because it does reduce the carrier state. And although we need to capture more information around this, we do have to still wear face masks around those who are not vaccinated, even though you are. So until the people that you're seeing and yourself are fully vaccinated, and fully vaccinated meaning that if it's a 2-shot treatment, that you have to receive both before you're fully vaccinated. There's certainly some local and inconvenient side effects. Not everyone experiences them, but there might be the local pain and redness of the injection site, which goes away. And then there's the flu-like symptoms that occur with some people. And that, again, is just an indicator that this vaccine is working and causing your body to be able to build that defense mechanism. The rollouts are certainly varying across the province, and they keep changing day to day, so it's really hard to speak exactly what's happening. But just so that you have an understanding, it's based on the geographical distribution of the population. It's also the risk of the population and the vaccine supply. And this is a real difficulty, that we have to base things on vaccine supply and also the availability of those who can do the immunization. So high-risk populations, of course, are immunized first. And with respect to the timing of the first dose and the second dose, this again goes back to vaccine supply. If we did have sufficient supply immediately, of course, we'd follow the clinical trials. However, then when there's not enough vaccine, the decision has to be made to consider, do we vaccinate more people and separate it out, or do we vaccinate fewer people? And we do know that vaccinations are working. Long-term care facilities in some provinces are allowing visitations again because everyone in the facility is vaccinated and there's comfort and the data is showing that it is safe. So in our real world data, there has been people who have received the first dose and have delayed the second, and it's showing that immunity and that response. And so it's not based on no data. It is based on some real world data, as well as some study participants who couldn't take their second dose at the prescribed time. So targeting spread locations where there's high spread, people with high levels of comorbidities, such as the elderly, all of those are going to be put as high priority, and each province may make slightly different decisions in how they do that. It is based on the evidence and the scientific data, but where the data stops, there has to be some interpretation by researchers, scientists, and healthcare professionals. Except for allergies to contents of vaccines, there's really no reason why someone cannot take the COVID-19 vaccine. It might be some timing with regards to some of the drugs, and we'll talk more about that later.
Thank you, Dr. Lowe. And Dr. Ahluwalia, I'm going to come back to you. And I think the next group of slides will be particularly important to our audience listening. We did receive many questions from people in advance and also tonight about people on specific disease-modifying anti-rheumatic drugs and biologics and the medications that they're on. So could you share with us what we currently know and what advice we give to people who are on various medications for their disease?
Absolutely. Those are two excellent questions. So let's talk a little bit about what I can expect after getting the vaccine. So as Dr. Lowe has mentioned, like any vaccine, there are some potential side effects, which are a sore arm for a couple of days, temporarily swollen lymph nodes, maybe some fatigue or headaches or muscle or joint pain. And these may last for a couple of days and usually do not require any treatment, although sometimes analgesics such as Tylenol can be taken if symptoms are severe. Some of my patients have received the vaccine, didn't have any side effects. Some of my colleagues who are healthy did have some muscle aches and pains and fever. In fact, I had a little bit of soreness when I received my vaccination for a couple of days. I couldn't sleep on that side, but eventually everyone recovered. The side effects of the second dose or the booster can be slightly worse, as it really suggests that your immune system is working and is more primed. So then the next question is, what do you need to know you have an autoimmune rheumatic disease? Is the vaccine still safe and effective? Well, there are two questions around this that I've posed. First is, will you mount an antibody response to the vaccine? And the second question is, what's going to happen to your disease? Could it potentially flare after taking the vaccine? So let's think about the first question. Will you mount an antibody response to the vaccine? We know that in the general population, the antibody response to the flu vaccine is about 50%. In fact, the COVID vaccines have the best response rate that we have seen for any vaccine thus far developed, 70 to 95%. Now, if you have a rheumatic disease, perhaps due to your disease itself, or even due to the medications you take, you may get a bit of a blunted response to that, to taking the vaccine rather. However, even a slightly blunted response is still better than not taking the vaccine at all. So it's very important that if you can take the vaccine, you should take the vaccine. The second thing is, will your disease flare after the vaccine? We have known from other vaccines, most of our rheumatic disease patients need to have all of their vaccinations up to date. We know that other vaccines have been safe. At this point in time, we don't have enough data around the COVID vaccine, but as we are monitoring patients after receiving the vaccine, we have not seen any serious or untoward effects. So should people living with arthritis get the vaccine, and which vaccine should you get? Absolutely, the vaccine is recommended for people living with arthritis. And the important thing is take the first one you were offered for provincial rollout for your age group. The Canadian Rheumatology Association, the American Rheumatology Association, the British Rheumatology Association all recommend that vaccines should be offered to people living with arthritis. So what about medications? If you are on immunomodulatory or immunosuppressive medications, it's important to understand perhaps what to do about those medications. So here I've created a table. This is information that is collected from the Canadian Rheumatology Association guidelines, recommendations that was done in collaboration with the Canadian Arthritis Patient Alliance. In addition, there is information from the American College of Rheumatology. Right here, I've presented the information from the American College of Rheumatology. So let's go through the table. The first medications at the top are methotrexate and JAK inhibitors. JAK inhibitors may be like upadacitinib, baricitinib, or tofacitinib, for example, and methotrexate, many of you may be either on it or familiar with it. So what you can do is get the first vaccine dose, and then after the vaccine, you would hold the medications for a week. So for methotrexate, you would hold 1 dose. For JAK inhibitors, you would hold a week's worth. Similarly, for the second vaccine dose, again, hold after taking the vaccine, your medications. Now, there's a little bit of a controversy around this because the Canadian Rheumatology Association doesn't think there's enough evidence to support holding these medications necessarily, especially if, for example, you are newly diagnosed, just started on the medications, you were flaring, or required a change in your medications, then perhaps it's not a great idea to be holding the medications. In that case, you go ahead and get the vaccination. There are other medications listed in the second box, in the second row: TNF inhibitors, Humira, Enbrel, Remicade, interleukin-6 inhibitors such as Actemra, interleukin-17 inhibitors, and other immunosuppressants. For those, there is no recommendation to hold the medications. Now, rituximab is a little bit different. What it is it's a B-cell inhibitor. So what happens is an infusion of rituximab is given, and then the B cells in your body are reduced to a low level in order to improve inflammation. Then what happens is they come back up and you give the rituximab infusion again. So the best time to receive the vaccination is when the B cells are coming back up. That's about 5 months after the infusion, as the infusions are usually given every 6 months. That's the best time to get the best response from the vaccine. So the first dose is given at 5 months. You can infuse rituximab about a month later. And then the second vaccine dose is a little bit more tricky because if it's being spread out to 4 months, that would put you in the middle of the next infusion. So it's not entirely clear what we should do at this point in time. Things are still evolving and we're still understanding this a little bit better. But then after the second dose, you would reinfuse. Abatacept is given weekly, subcutaneously, and IV. There are recommendations for that medication as well, as are listed here. And prednisone. Prednisone is interesting because if you require the use of prednisone, chances are you need what you're taking and the dose that you're taking. Now, it's certainly possible that the dose could be changed by your doctor, but it's best to speak to your doctor. Do not stop or lower the dose on your own. That is not recommended. The decision to alter or hold medications should be a shared decision between you and your physician. And in some cases, as I mentioned, it may not be safe to do so. Sometimes the best thing to do is to continue your medication as prescribed and get the vaccination. So what about when you've been fully vaccinated? What kind of privileges will that give you? Well, the Centers for Disease Control in the US has made some recommendations as per the beginning of this month. These recommendations have not yet been approved in Canada, but I'm sure that the public health is certainly working on thinking about this. So if you've been fully vaccinated, it's possible that you could gather indoors with fully vaccinated people without wearing a mask. I'm sorry, I didn't advance the slides. There you go. Gather indoors with fully vaccinated people without wearing a mask. You could gather indoors with unvaccinated people from one other household, as long as they are not at high risk. But as Dr. Lowe has mentioned, in public, you should still wear a mask, stay 6 feet apart from others, and avoid crowds and poorly ventilated spaces, because what we need is herd immunity. That is about 80% of the population needs to be vaccinated before we can be comfortable changing our practice. So what do we know and what are we still learning? A few thoughts around this. We know the vaccine, as Dr. Lowe has mentioned, is very effective at preventing COVID-19 disease, especially serious disease, hospitalization, and death. But we're not really sure what to do about the variants of concern. We know that virus mutates as it moves from host to host, and it changes its spike protein, okay? There are many variations that occur over time. However, it's really the variants of concern, the ones that are more serious, for example, from the UK or perhaps from South Africa, that are coming to our country that we have to be concerned about. More variations are occurring, and some of these variations have increased transmissibility and may cause more severe disease. So up until now, the vaccines that were developed were against the Wuhan variant, which is the very first kind. So we're not sure how they're going to help against this. This is still being investigated, and we are observing very intently. The best way to keep the variation down is to stop the virus in its tracks. You prevent it from moving from person to person. It can't vary, and that's why vaccination is so important. What about other prevention steps to help spread the spread of COVID-19? These steps are still very important. We're still learning how the vaccines help stop the spread of the disease. We know the carrier state is reduced, so that is helpful. Now, we know that from getting the COVID infection, like you get natural immunity or antibodies for about 3 to 6 months, we're still learning on how vaccines protect people. As Dr. Lowe mentioned, we may need to re-immunize people at some future date.
Thank you, Dr. Ahluwalia. So I think COVID has fairly changed everybody, but could you speak a few words about what can we expect when things get back to our new normal, and should people still be careful as they are now?
Absolutely. Until we know more about these questions, everybody, even those people who have had their vaccinations, should continue the basic prevention steps because they do work. Wearing a mask, staying 6 feet apart, not gathering in large groups, and using hand hygiene. So it's very important to stay informed. Don't let the information on the media overwhelm you. Make sure you're getting your information from reputable websites, many of which we have included and listed here. So my recommendation is that you should get vaccinated when you are eligible. Timing may be important for a few drugs that I've mentioned, but the rest of the time, keeping control of your disease, taking your medications as prescribed is very important. If you don't feel comfortable getting vaccinated, discuss this with your healthcare provider or your rheumatologist, and you can wait for more information. Getting vaccinated helps protect yourself, your family, and the community.
Dr. Lowe, I'm going to turn it back over to you for a moment before we get to the live Q&A. Do you have any last thoughts before we share that you want to share with our viewers before we go to the questions?
Thanks, Sean, and thanks for giving me kind of the last word before going to Q&A. I just want to say that from a pharmacy perspective, that many are adapting. So when you're getting your medications, do recognize that many are offering complimentary medication delivery, so it can save you a trip out. There's also telephone and potentially video consultations that they're doing and providing counseling about your medications through a more virtual means. And just like physicians who are offering virtual medication or medical assessments, which you can also take advantage of. So do plan ahead, get your refills, but don't hoard. Remember that delivery takes longer than usual, so you can't just count on it, and don't cut it down to the last couple days. We've seen the mishap in the Suez Canal, and delays can happen. And don't stop your injections, infusions, or medications. Certainly consult with your physician about the best timing with respect to the COVID vaccine. It might take a little bit of adjustment in relation to your immunomodulating drug and other vaccines that you're taking. I'll pass the attention back over to you, Sean, as you take us through the Q&A.
So thank you so much, Dr. Lowe, Dr. Ahluwalia. That was a great session. I will just mention before we get started, I know that we are having some issues with our external server. So if there is any part of this presentation that you missed, don't worry. The video, the recording will be available for you tomorrow, so not to worry. So we have received many great questions. I think we should probably just get right at it. Many of them revolve around the vaccine, as you would expect. So my first question really is around, we know that early on, rheumatological or arthritis patients, immunocompromised patients, were not included in clinical trials to understand the vaccines. Could you just explain for us why they would have been excluded in the first place?
Should I take that?
Yes, please, Dr. Ahluwalia.
Okay. So the way clinical trials are conducted is they have a phased approach. So they have a phase 1 where they look at healthy volunteers and they look to see if the intervention that is given is safe. Okay. Then they go on to phase 2 and 3 studies where they look to see if the intervention is safe or if it's effective. And so we need to know both of those things. And they include patients with multiple different diseases and medical conditions and so forth. So I did review one of the vaccine companies' register, and they did mention that they potentially had offered inclusion to rheumatic disease patients. However, what you do in order to make some conclusions in terms of those, the clinical trial results, you need to have large populations. And if you don't have a large enough population, you might make the wrong conclusions. So for example, if you have very few patients with rheumatic diseases, then it may look like the intervention is really good, or it might look like it's really bad. So it can kind of skew the results, and that would not be helpful in terms of understanding what that means. So not a lot of patients were included in these clinical trials, and therefore we don't really have enough information to make recommendations. So I think that's really the reason that we don't have enough information. But as Dr. Lowe mentioned, when we have phase 4 trials, when we're looking at the general population, we're doing observational assessments. You know, the Global Rheumatology Alliance is following patients, so are other registers. We're going to find out more information and see if there are any serious concerns.
Thank you. And Dr. Lowe, you gave a really nice description of the different vaccines that are available. And really clearly, both of you sent the message that you should take the first vaccine that is available to you. But is there one vaccine that is safer than another for arthritis patients?
So I'd just like to kind of really discourage that. That question really comes because people are thinking of vaccine shopping or trying to consider one's better than the other. There's just multiple options that are out there. And of course, we have differing levels of data on different ones. And there's a lot of hypervigilance that's going on right now. These trials did go through relatively quickly, but they did go through in 50,000 people per study. And before anyone receives the vaccine, there will have been millions who have been vaccinated across the world. So, you know, there is a lot of data and evidence. However, we are just so sensitive to every report that we are capturing, reporting, and then we actually ask and act with an abundance of caution. So much so that sometimes the information comes out with people jumping to conclusions. And we've seen that with the AstraZeneca vaccine, which is why you're seeing this jumping back and forth and some people perceiving that maybe this is not as good of a vaccine. And it's really just about the information and the data of when it's coming out. When it was reported that it should not be used in those over 65, that was based on the earlier trials where patients over 65 weren't enrolled. Since then, there were European trials that did enroll the elderly, and now we have good information, which then caused the change in recommendations. This sensitivity of reporting these blood clots that have occurred, again, it's because of being very sensitive to every single side effect that's being reported. And even though the incidence of these are essentially the same or less than what's in the population normals, it's just being captured because someone received the vaccine and it's reported as a coincidence for that. So you shouldn't take these information to decide on whether this is a better, worse, or good vaccine. You know, the other thing that you should also think about is chances are this is not going to be the first and only COVID vaccine you're going to get. With what we're seeing, likely there will be annual or some periodic revaccination with other vaccines that are going to happen. So you don't want to delay. You can imagine that if you delayed, as in the long-term care homes, if there were a few holdouts saying that they wanted to wait for a certain vaccine, that would mean that visitations couldn't go on because there would be essentially residents who were not vaccinated and therefore compromises everything else that's being planned and happening. So it goes back to, all the vaccines are safe and effective. They've been approved by Health Canada, who are especially vigilant and also very careful in the approvals. So it's not just approving everything, and there's continued surveillance as we go on. So you should feel that any vaccine that is approved in Canada is safe and is effective. And if there are changes, they'll be very quick to jump on it, and sometimes too early, but that's safer. So get the first one that's offered to you that you are eligible for. Get protected.
So of course, Dr. Ahluwalia, these vaccines stimulate the immune system. Is there any evidence around actually promoting flares in people with arthritis?
Mm-hmm. So that's a really good question. We're always interested in that because you worry about anything affecting your immune system, taking it over, suppressing it, and so forth. So those are important aspects to patients with rheumatic diseases, and of course, due to the medications that they're taking. So a couple of things that we know is that, remember, these vaccines are not live, okay? So there's no virus particles or anything like that would affect you in any way, because live vaccines are not recommended in persons with rheumatic diseases. It potentially could cause infection and stuff. So we know that that's the case. The other thing is that we know that the messenger RNA doesn't really integrate into your body's DNA or anything like that. So we're not worried about that. There's a couple of theories around potential flares, although so far we have not seen that in any of the observational databases or anything like that. So one of the things is that if the antigen or the vaccine and an antibody that you produce comes together, it produces what we call an immune complex. Those immune complexes can sometimes precipitate in organs, cause inflammation, organ dysfunction. That's one of the potential means, but we really haven't seen that. The other possibility is that you have these receptors called toll-like receptors. And what happens is the toll-like receptors are very important in terms of triggering the immune response to the messenger RNA vaccine, but they're also important in some autoimmune diseases. And so the question is, could this vaccine stimulate what we call the innate immune system and cause a flare of the disease? So these are two theoretical concerns, but really we have not seen any issues in terms of flare of disease thus far. We've been vaccinating patients with rheumatic diseases with many other vaccines, and again, no serious flares of disease have been seen.
Okay, so Dr. Ahluwalia, if I could stay with you for a second, what should patients do if they are getting somewhat conflicting information from different healthcare professionals around the vaccine in particular? What would your advice be about where they should go for trusted information?
So I think it's important, first of all, the healthcare provider, the rheumatologist perhaps that you are seeing is going to be your trusted advisor. Your pharmacist is very helpful there as well. We have indicated some websites that are available for information around vaccination. Of course, public health is there to help you. So I think all of those areas are going to be information access for you to understand what you need to know.
Okay. Dr. Lowe, if I could go back to you, there are questions here about the spacing between the two vaccinations for those that require them both, and concerns around immunocompromised patients in particular waiting longer than what would have been tested in those clinical trials. Could you give a little bit of perspective on that, and if there truly are concerns about widening the gap for immunocompromised patients?
Thanks for that question. It is a tough one, and it's because there's a lack of information and study around that. Obviously, that wasn't the purpose of these studies, to study a longer duration than what was recommended to start with. And with immunocompromised patients, certainly there is a theoretical concern that spreading it out may not be the best approach. However, we just don't know. And it comes down to, I guess, interpretation and professional opinion on this. And there could be different ways to interpret this. Ideally, we would like to give the vaccine as it was studied. Problem is that we don't have enough vaccine supply, which means that you've got to make other decisions. And this is where public health officials, doctors, scientists, and researchers have to come together to try to determine what would be the best approach. Now, some of this might be changing, And we're waiting for, I guess, more data in a real world sense to see if we can get a better handle on this. But we are seeing that in some circumstances, and this is being reported in the elderly as well, that they may not be able to last as long between doses because of their immune system being different. So until we get further data, we're going to have to go with what the recommendations are on the best evidence we have. And everybody's trying to do their best. Everyone is using, the theoretical knowledge, putting science and interpretation and extrapolation to work. And we're extrapolating from other vaccines as well. Some of it is actual data. So we do see that after a single dose, there is a prolonged protection beyond the usual 2, 3, 4 week separation that might be recommended. But how long it actually lasts, we don't have that kind of data. And so we're not sure at this point. And so we can't really give an answer, but we do know that some protection is better than none. And that's going to be clear. And taking any drug, it's always a risk-benefit consideration. You consider the risks of not taking it and the risks of taking it. And despite all these side effects and everything that we're hearing, without the vaccination, things would be certainly worse for that individual, for the population. So this risk-benefit assessment is what you should do with your healthcare professional. And just to speak a little bit about who should you trust, your licensed healthcare professional is going to be the most trustworthy source of information. They are licensed and trained and regulated to make sure that they're providing the best information they can.
Great. And maybe I'll end, Dr. Lowe, with one last question for you. And that is really, given that there are multiple vaccine options, around interchangeability of doses. So for example, can you receive your first dose from one company and receive your second dose from a different company, and the implications of that?
So at this point in time, all the data is implicating that you should get the same version that you got the first dose with. Now, data is accumulating. And again, if we were in a perfect world and there was enough vaccine supply, we'd make sure that you definitely get the second dose of the same one. There are now surveillance studies that are going on to watch, and in other countries where they've just had to run into the situation. So it ends up being studied because this is the practicality, this is what's happening in the world. So you capture information around it. I think what we're doing in Canada is to make all efforts that you get the same type of vaccine that you got for your first shot. It's recorded, and you should keep track yourself as well. You would have gotten some sort of documentation when you got your first vaccination, and do keep track of what that one was. And your aim would be to try to get the same one as the second shot.
Great. Well, thank you again, Dr. Lowe, Dr. Ahluwalia. That was really fantastic. Lots of very helpful information presented today to help people living with arthritis manage through these challenges presented by COVID-19. As we said before, the video and presentation slides will be emailed to all registered participants this week, and the recording of this webinar will be posted to our website very shortly. I also encourage you to visit our website, the COVID-19 section at arthritis.ca/COVID-19 for current information about COVID-19. We would like to just take a few moments to get your feedback on today's presentation. So those of you on a laptop or a desktop computer, you will see a poll question coming up on your screen with a yes or no answer. So please do click on the response that reflects your thoughts. Did you find the information in today's webinar helpful to you? We will also be sending an evaluation form when we send out the recording. So if you weren't able to access the poll question or you'd like to give us more feedback, please go ahead and take that opportunity too. Once again, thank you to Pfizer, Novartis, United Way Winnipeg, the Province of British Columbia, BMS, UCB, and Cordelex for their financial support of our Arthritis Talks series. We invite you to support us as we work to continue to create valuable resources to help you better manage your arthritis. So if you are able, please consider visiting arthritis.ca/donate. Our next webinar, Arthritis Talks, Accessing Care from Anywhere, is coming up on Thursday, April 22nd. To register for that event, please visit arthritis.ca/arthritis talks. This concludes Arthritis and COVID-19, Vaccines, Access, and What's Next. On behalf of all of us, thank you for joining us today, and please do stay well.